This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Tesha Monteith with the Neurology podcast. I'm here with Professor Messoud Ashina, affiliated with the University of Copenhagen. He's here with me to discuss his breaking paper just published in the New England Journal of Medicine called A Monoclonal Antibody to PACAP for Migraine Prevention. Messoud, thank you so much for being on the podcast with us. How are you?
Thank you for the invitation. Happy to be here again.
This has been, I think, a long journey, right, into understanding the biology of PACAP and what it means for migraine, and now this wonderful phase 2 study. So why don't we just start with the biology?
Current understanding of migraine, it's based on migraine anatomy and physiology. Anatomy and physiology, if we talk about the substrate of migraine, we talk about the trigeminal vascular system. And what we also know that the activation of this system is associated with the release of the different chemicals, transmitters, and one of them is PACAP, pituitary adenylate cyclase activating polypeptide. One might be surprised that the name of this peptide was something to do with the pituitary gland, but it is not only pituitary gland. The reason for that is that because it was discovered in the pituitary gland, and that's why it was coined as a pituitary adenylate cyclase activating polypeptide. But this peptide plays a quite significant role in the various biological processes, including vasodilation, pain transmission, and neuroinflammation. Its implication in migraine pathogenesis starts with the first observation when it was shown that the PACAP infusion can trigger migraine attacks. That was a very interesting observation at that time, and it actually set into motion a lot of studies afterwards, both in humans but also preclinical studies, to understand the mechanism by which PACAP is inducing migraine attacks. What we know also about the PACAP biology is that PACAP exists in two isoforms in human body, PACAP 38 and PACAP 27. The first study in 2009 was with a PACAP 38. And exactly 10 years after, there was another study we conducted with a PACAP 27, another isoform, which also showed that it induces migraine attacks more than half of the people with migraine. Again, suggesting its important role in migraine pathogenesis. What we also know from human studies that the PACAP is a very strong vasodilator, and in fact, it induces long-lasting dilation. And from some of the studies in healthy volunteers, we also showed that sumatriptan can actually constrict this vasodilation of the cranial vessels. And later, we conducted a study which showed that early treatment with the sumatriptan can in fact prevent PACAP-induced migraine. So all these studies together stimulated the companies to develop drugs acting on PACAP pathway. And the first one, in fact, was antibody against the PAC1 receptor, because this receptor was identified as a possible candidate, as a target for migraine treatment. But unfortunately, this trial failed, showed that there was no effect on migraine prevention when the antibody acted against PAC1 receptor. So when we talk about the receptors, I have to mention that there are three important receptors PACAP is acting on: VPAC1, VPAC2, and PAC1. So as I mentioned that the PAC1 study, the antibody against PAC1, failed to show efficacy. It was safe, but not effective. There were many discussions about that. Some people suggested maybe the drug was not potent enough. Maybe it was a different splice variant of this receptor which should be targeted. So a lot of questions. But eventually, some companies start thinking about blocking the ligand, the monoclonal antibody against the ligand, against the PACAP. So this study that just been published in New England Journal of Medicine is a study where the anti-PACAP monoclonal antibody, anti-ligand monoclonal antibody, was investigated in people with migraine who failed 2 to 4 previous medications, prophylactic preventive medications. And people with episodic and chronic migraine, they were included in this phase 2 proof of concept study. So that was very important to show whether it works in migraine, yes or no. But before we can talk about this study just published, I'd like to mention a very important study that was conducted prior to this phase 2 proof of concept. I would call it a phase 1 proof of mechanism study. So in this study, we speculated whether this monoclonal antibody against PACAP can prevent logical effect of PACAP 38 in humans, in people not reporting migraine, in other words, healthy volunteers. So we were expecting to see vasodilation, increase in heart rate, flushing, all these symptoms that usually we associate with the PACAP infusion. So this phase 1b study was successful in the sense that we showed clearly that this monoclonal antibody completely blocked these physiological responses of PACAP, increasing our confidence that we can go and now conduct a proof of concept study, which is now published in New England Journal of Medicine.
There's some similarities between PACAP and calcitonin gene-related peptide in terms that infusions trigger migraine. Early treatment with sumatriptan can resolve a migraine attack or prevent a severe headache. Do we see the same correlation with severe headache and increased PACAP levels, and as well as elevated levels in people with chronic migraine?
One of the problems with biochemical biomarkers is that lack of the standardized validated assay. That's why you might see some studies showing some elevation, other studies decrease, other studies at normal levels. And this is a problem that we also face in studies conducted to show any changes, alterations of plasma concentration of the CGRP. And by critical review from one of the famous logical experts, Debbie Hay, showed that most of these assays that commercial available talk about the CGRP, in fact, not measuring the CGRP. So there are a lot of questions there. That's why we have to be very careful with interpretation of this plasma concentration status, because unfortunately we don't have a clear-cut blood-based biomarker of CGRP. I think that the interesting question is about similarity, whether the CGRP and PACAP 38 or PACAP in general share some mechanisms of migraine induction. We don't think so. We think that CGRP is acting on its own receptors and PACAP is acting on its own receptors. And you might speculate that whether this mechanism some way interact and they are dependent on each other. Meaning that if you give the PACAP, maybe the migraine induction is due to, let's say, release of CGRP, and CGRP is in fact also a reason, a cause of migraine attack induced by the PACAP. I can disclose you an interesting study which is not yet published, but we are just completing the manuscript ready for submission, where we investigated whether the monoclonal antibody against CGRP can prevent PACAP-induced migraine attacks. And guess what? This study showed that anti-CGRP monoclonal antibody failed to prevent PACAP-induced migraine attacks. And this opens up for the prospect of, in the future, maybe a combination treatment. If the anti-PACAP treatment or therapy will be established and firmly confirmed in phase 3 study, then we can speculate about the combination therapy. This is a very interesting prospect.
Why don't you tell us about the design of the study?
The design of this study, the phase 2 study, was a double-blind, randomized, placebo-controlled trial. So this trial enrolled adults with migraine who had failed, as I mentioned before, 2 to 4 previous preventive treatments. So the trial involved 4-week treatment period with a single dose of either 750 milligram or 100 milligram of monoclonal antibody against anti-PACAP or placebo. And that was, of course, followed by the 8-week follow-up period. Usually we do it for the safety. And participants, they were aged from 18 to 65 with a history of migraine. And of course, in this study, all significant comorbidities and conditions were excluded because it is a proof of concept, very early study. So that was the design of this study. Straightforward and a single intravenous infusion. And the primary endpoint was reduction of number of migraine days compared to baseline. And this was against placebo, of course, during the first 4 weeks treatment. So it's only 4 weeks treatment, a single infusion.
Great. And so what did you find?
So what we found that a single dose, primary endpoint was the highest dose, 750 milligram. That was a study was powered to, showed that this dose significantly reduced number of migraine days compared to placebo. I can tell you that 50 milligram arm included 97 patients and placebo arm 94 patients. And what we found that the decrease of 6.2 migraine days per month from a mean 16.7 at baseline. And at the placebo arm, it was a decrease of 4.2 days per month from the mean of 16.9 days at baseline. So that was a significant difference between the two arms. Pretty similar, actually, what we've seen before also in clinical trials on CGRP monoclonal antibodies.
Were there any important safety signals or issues with tolerability?
Most of adverse events here in this study, they were mild, okay? In this group of 750 milligram, we had a higher incidence of COVID-19, nasopharyngitis, and fatigue than at the placebo group. But in this kind of study, it's very difficult to evaluate firmly about whether these adverse events that I just mentioned are related to the medication because of the multiple centers included. And we all know that there was some on and off COVID-19 pandemics during this period or epidemics, and this could affect it. So we have to mention also the limitation and remaining questions because the sample size here in this study was small and the duration of the trial was short, only 4 weeks. And all trials, we have also participants. Most of the participants were European in this study. So we need more studies, clearly more studies. And also we need that will be a 2B study where the dose will be determined and also subcut formula will be also tested. And then hopefully very soon phase 3 study to firmly establish its efficacy, safety, and tolerability.
And so this drug was an infusion, not a subcutaneous injection.
Correct. That was an intravenous infusion. Yeah.
And is the thought that for repeat dosing, it would be a monthly dose or more similar to eptinezumab?
It will be probably a design, the monthly doses every month. This is a usual principle of monoclonal antibody. This is a difference from the small molecules which should be administered every day because of the short half-life. With monoclonal antibodies, it is an administration form, and usually it's a 1 month half-life. So that I expect that will be every month for 3 months, future phase 3 trial. Also, then we will probably have the same primary endpoint, and it will be probably comparing the last months of the treatment to baseline, and again, against placebo.
What evidence is there that targeting a PACAP is safe?
So far, the evidence comes from these studies that I mentioned in healthy volunteers, phase 1 and 1B studies. In this proof of concept study, we don't see any safety signals here in this number of patients that, as I mentioned before. So at least for this trial, I can say that we don't see any alarming signals. This is a widely distributed peptide. And of course, if you want to claim or state something on safety tolerability, you need a larger sample size study and phase 3. Here, as I told you, it is 97 participants for 750 milligram and 46 participants for the 100 milligram, and it was a 94 for placebo. So it's a relatively small study, proof of concept study, typical. So far, fortunately, no serious safety signals. We will see in the future.
Now, you may not have been powered for this, but did you recognize any dose relationships between the 100 milligram and the 750 milligram?
This study was not powerful to see the dose relationship. So far, we can just speculate some numerical the differences. But I think that for this purpose, you need a dedicated study.
And it's a monoclonal antibody, so I guess the thought is that it's targeting the periphery, but there's some question to even the CGRP monoclonal antibodies and their ability to get in the brain. Recent studies like fremanezumab. I'm wondering if any of those studies are planned.
Everything that, even if it acts in the periphery, has effect on the central nervous system. Because the current understanding of migraine is that it is a brain disorder, yes, but what we see that the drugs acting outside of the blood-brain barrier, outside of CNS, may actually have some effect also on the central mechanisms. So the system is not just a separated system. It's an interdependent system. So we have to be careful when we talk about that. The study that you're mentioning, the fremanezumab study that's showing that concentration in the CSF, in reality doesn't say that it is in the brain, because having something in CSF doesn't reflect necessarily the brain. In order to see something in the brain, you need a completely different type of studies, which would be a bit difficult to do in humans. And also, what is interesting about all these monoclonal antibodies so far, we don't see any CNS side effects. Usually when you see that the drugs is acting on the central nervous system, you expect also CNS side effects. One example is topiramate. We all know, clinicians, when you treat people with topiramate, one of the things that we usually inform our patients about is cognitive side effects, right? And you don't see that with monoclonal antibody. It's super well tolerated in the most of the cases. Sometimes you might see, of course, some allergic reactions, completely different story, but not CNS-related side effects. That's why I'm not concerned about that. But of course, that the people interested in science, there is a still ongoing debate about to what extent the central nervous system influence the trigeminal vascular system, which is the most important one, which is the most important button you push and you activate the system. This debate is ongoing, and I don't think it's the treatment efficacy will tell us that it is a central or peripheral, at least now. We don't know.
What other potential headache disorders, such as cluster headache, may be important when thinking about targeting PACAP?
The people with cluster headache, they need new treatments, no doubt about that. It is a very painful condition, and unfortunately, our treatment possibilities are limited. There are different reasons for that. But the most important also that there is still delay of diagnosis for cluster headache patients, and also not really many treatment possibilities. I know that one of the monoclonal antibodies is approved, at least in North America, but not in Europe. So we cannot actually prescribe Emgality or galcanezumab to people with cluster headache, with episodic cluster headache. And we know also that the trials so far in chronic cluster headache patients didn't really show any efficacy of monoclonal antibodies again. So this is evidence, right? But cluster headache is important, and what is important also, we studied in my group the possible signaling molecules important for the genesis of the cluster headache attacks. And we showed actually that the PACAP induces cluster headache attacks in patients during the active periods, during the bouts when they have cluster attacks, and also in patients with chronic cluster headache, but not during the remission. This is a fascinating question. Why? Not inducing during remission. All side effects of PACAP infusion, physiological effects, but no cluster headache attacks. There is a lot of debate about that and could be some explanation for that. I know that we suggested that could be possible central mechanisms important for regulation of this activation of trigeminal vascular system, which basically switch off completely all the possible triggers and painful signals which might come from the activation of the trigeminal vascular system. And that's why they don't report cluster headache attacks during the remission when we infuse PACAP. But alone, just infusion of PACAP inducing of cluster headaches suggests that the anti-PACAP therapy could have a potential in cluster headache patients. But again, we need trials, because cluster headache is always something that surprises us when we really hope that might be something there, but it's not there. It's a bit different from migraine, and that's why it would be important to study that in the future. But I expect also cluster headache as a possible candidate. Another candidate group I'd like to mention is a post-traumatic headache. One of our groups at the Danish Headache Center, they also showed that the PACAP infusion caused exacerbation of post-traumatic headache, resembling those exacerbations that the patients experienced before they experienced in more than 90% of cases when they received PACAP infusion. So they're extremely sensitive, hypersensitive for PACAP. If we can speculate that anti-PACAP therapies can be used for the post-traumatic headache, that would be a fantastic news for people who report chronic post-traumatic headache, because we know that it is very refractory and no specific medications. And actually, the medications that we usually use for migraine prevention or tension type A prevention, not really working in the post-traumatic headache. That will be really interesting to study that in the future.
I love the idea of the potential of this therapeutic. I want to get back to something that you raised about CGRP versus PACAP and potential different pathways. How do you see this drug? We now have over 5 years of experience with CGRP inhibitors, and there's so many patients that have benefited from these treatments, but then there are patients that clearly are non-responders. How do you see, if phase 3 studies go on to be positive, how do you see this in clinical practice?
Let's assume that the phase 3 study with anti-PACAP, monoclonal antibody against the PACAP would be successful. I see the practice in this way. We will have another monoclonal antibody available for migraine prevention. It will be in the same level like an anti-CGRP, and it will be up to the physician and up to the patients to decide which of the monoclonal antibody we will administrate as a first choice, let's say. If it's successful, regardless if it is anti-PACA or anti-CGRP, we will continue treating the patients with this monoclonal antibody. If it's not successful, we have a possibility to justify the switching from one signaling pathway to another signaling pathway. But if we start with anti-PACAP, we can switch to anti-CGRP. If we start with the anti-CGRP, we can switch to the anti-PACAP. This is the second scenario. The third scenario is that you have one of your patients with migraine telling you there is some reduction, let's say from 25 days to 15 days. It's a lot for the patient, but still I have 15 days with migraine. And after this 1 year of treatment, you don't see any further effect of monoclonal antibody against CGRP or its receptor. You might speculate, maybe I should add another signaling pathway monoclonal antibody and have a combination. So I'm talking about the combo treatment. So this will be a possibility. Of course, state of the art should be a randomized clinical trial showing the benefit of the dual therapy against monotherapy. That will be an excellent idea to do this kind of study. But I don't know whether the companies will be interested in that. But at least the clinicians, they can actually, together with other colleagues from other countries, to propose in-house multi-center trial to see whether the dual therapy will have more benefit than the monotherapy. This is a third scenario I imagine in the future.
We definitely need long-term studies, but the benefit of this primary outcome measure is that we know that it works early.
Yes. What I say that it is pretty similar what you see also with the CGRP monoclonal antibodies. But again, I'm clinical scientist. We have to be careful and ask for more study, most importantly, phase 3 study to confirm what we've seen now.
We certainly need continuation of efficacy.
Absolutely. And also in the future, Tesha, I also imagine that there will be probably long-term open label extension arms when we can see how sustained effect is of this drug and also tolerability and safety, at least for 1 year or something like that. Because you also raised the question about the tolerability and safety. So that's why this long-term study. So we will probably see the same, let's say, chain of the studies that we've seen with the anti-CGRP monoclonal antibodies, at least what I expect.
Congratulations again on the paper. It's outstanding to you and your team. And many people listening on the podcast probably don't know how long you've been going at this, you and your group. So you should really be proud of yourself.
Thank you so much, Tesha. Thank you for your kind words. And I'm really happy for patients because it gives them hope that maybe something new is coming.
You're a friend of our Neurology podcast, so we do appreciate you coming on to share the great news.
Thank you.
And thank you for listening. This is Tesha Monteith with the Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.